Good evening, everybody, and thank you for joining us today. We're obviously here to have a chat about women's health. It's such a hot topic at the moment, and this is part of our Women's Health Month across the modality Airedale, Wharfdale and Craven area. So we thought it'd be nice to have a chat this evening about what interesting topics do we often speak to people about regarding women's health, and answer some questions from you all. So my name's Dr. Tessa Mayo. I'm a GP with a special interest in gynecology, and I'm joined by my colleague Lisa, who is one of our advanced clinical practitioners who also works in the area. So in terms of what we're going to talk about today, well, really what we want to think about is the life course of a woman. So that begins right at puberty, with starting your period and any issues you might have in relation to that. We're going to talk a little bit about family planning and reproductive health. And then we're going to talk about later in life and the menopause and what changes and what things might happen at that stage of life. Now, it's also really important to talk about things like cancer screening, because obviously there's breast screening and cervical screening that are available. And we'll talk a little bit about ovarian cancer awareness whilst we're here. Unfortunately, there's some topics that we just don't have time to cover. And women's health is such a big topic. There's things like sexual health and pregnancy care and pelvic floor health, so prolapses and pessaries, that we just don't have time to talk about today. But if you're having any issues like that, go and speak to a clinician about them, because these things are really common and there's lots that can be done to help people. So when we think about the life cycle of a woman, so as I said, we've got all these different areas of our life. We've got when we're adolescents, when we're in our middle years, and when we're in our later years. And there's various different issues that occur as part of a woman's health needs. And some of them will cross over several areas, like their menstrual health. Some of them are more specific, like their menopausal health. But there's lots of different things to think about when we talk about women's health. So starting at the beginning, starting your periods. So what are our periods? So periods are the time when a woman bleeds from a vagina for a few days. And they're a normal and natural part of the life cycle. And it's really important to try and talk as openly as possible to girls and boys about periods in the menstrual cycle, and using accurate terms such as the word vagina, so that people understand what's going to happen and what's happening. And we know that actually, although the average age of the first period is 12 years, it's quite variable. And some people will start their periods as young as 8 and other people as late as 17. So there's quite a wide spectrum there. But what we do know, it's usually around 2 years after the first signs of puberty. And we would recommend that if at 15 you've not started your periods, it's probably worth just booking to have a chat with your clinician about what's happening. Now, when periods start, they can be quite irregular, and it's very common in the first year that cycles are irregular, and you might have a period and you might not have one for a couple of months, and then you'll have another one. So that's quite a normal thing to expect. Unfortunately, it makes them a bit unpredictable, which can be challenging. And in terms of what your bleeding pattern's like, well, again, it's quite variable, but on average, people will bleed somewhere between 2 and 7 days every 23 to 35 days. We also want to point out that once you start having your period, it's important to talk about contraception, because once somebody starts having their periods, they are at risk of becoming pregnant if they're sexually active. So it's good to start talking about contraception early and just making people aware about that. So in terms of our periods and what we call our menstrual cycle, which is the cycle that we go through on average every 4 weeks or 28 days, which starts with day 1, which is when our period begins. And that's when the lining of the womb, the uterus, breaks down, and you'll see that you have bleeding. And that lasts for a few days, up to a week, at which point then the uterus lining starts to build up again. And you won't see anything at this point, but in the background, your lining of your womb is starting to thicken. Your body will release an egg about halfway through, and then it'll maintain the lining of the womb. And if you don't get pregnant, then you'll have your period again. So this is what is happening in our bodies. Now, unfortunately, there are problems that people can have with their periods, and that's where we come in as clinicians. So heavy periods is something that's a really common issue. And what we'd say is that, in theory, if you have more than 80 mils of blood loss, that's classed as a heavy period. But really, if somebody perceives the bleeding to be heavy, if they feel that the bleeding is heavy, if they're passing clots, if they're flooding, so they're standing up and they're getting gushes, come and talk to somebody about it, because it's something that there's various things that we can do to help. Now, sometimes it's just what that person's periods are like. It can be signs of other health conditions, particularly if it's a change in your periods as you're older. So it's worth just bearing in mind that if there's a change in the heaviness of your bleeding, that you should report that and speak to somebody about it. And it can have complications. So if you have excess blood loss, you can become deficient in iron and anemic, and that can present with things like tiredness and breathlessness. So it's worth bearing that in mind. Why do we have heavy periods? As I said, it can be normal for the woman. It can be due to things that are related to the womb. So things like fibroids, where we have a larger area of the surface of the womb, can cause heavier bleeding. Or it can be related to things that are due to other things in the body. So things like thyroid disorders and blood clotting problems. But in general, what we try to do is treat any cause that we find, treat any iron deficiency, any low iron that we find, to get people feeling better. And if we need to, we'll start thinking about other treatments. So that can be things like a hormonal coil, which is a fantastic treatment for heavy periods. About 90% of women will have less bleeding after 6 months of having a hormonal coil. So it's really, really been sort of transformative in terms of managing heavy periods. For those women who that's not suitable, we might consider something like tranexamic acid, which is a tablet you can take for 4 days during your period, which just helps reduce the heaviness of the bleeding and the clots. And some people will take the contraceptive pill as well, because that can reduce the heaviness of the bleeding, and also it can reduce the frequency of your periods depending on how you take it and what regime you use. So, there's various different options, and obviously it depends on the person and what you would like, whether you want contraception, what your preferences are. But there's certainly things we can do about it. So come and talk to us. And if we try all these things and they don't work or they're not suitable, there are things that we can do by referring you through to hospital as well. So they might offer various procedures. So as I said, the key thing is come and talk to us about it. As well as heavy periods, some people suffer with really painful periods, and how people describe the pain periods can be really variable. So some people feel it in their abdomen, in their tummy, some people feel it in the back, some women feel it in their thighs. Sometimes it can be a sharp pain, sometimes it's a cramping, sometimes it's an aching. And it can be related to how heavy your bleeding is. So some women find that when they're bleeding more heavily, their periods are more painful. Now, we know that it can be a sign of other health conditions. So that's things like endometriosis and fibroids, as we mentioned before. And it can really be quite detrimental for people. So people missing school, missing work, missing the things that they enjoy in life because their periods are painful. So again, it's thinking about, what can be done to try and help with the heaviness of them. So general advice is sometimes a nice warm bath or a shower will help. Heat and massage of the abdomen, and actually doing some gentle exercise has been proven to help painful periods as well. So trying to just keep gently active is useful. Paracetamol can be helpful for painful periods. And when we say NSAIDs, we're talking about non-steroidal anti-inflammatory medication. So that's things like ibuprofen, but there are other things that we can use, things like naproxen or mefenamic acid, that can be helpful. It's just important to make sure that you only take one of these group of medications at a time. Another thing that we think about is contraception, because actually one way of managing painful periods is through using various different types of contraception to try and reduce the frequency of periods that people are having and the severity of them when they do have them. And there's also surgery that can be useful depending if there's a specific underlying cause as well. So, as well as heavy periods and painful periods, unfortunately, some women have irregular periods. And that's what we would say when your periods, when your gap between your periods is either less than 21 days or 3 weeks, or more than 35 days. And that's pretty common around the time of puberty. So when your periods are first establishing the pattern, and the perimenopause. So when you're getting towards the end of your period, it's more common to have an irregular cycle. And often irregular cycle can be one of the first signs that people are heading towards the menopause. There are other things that can affect your periods, and lots of women will have experienced things like stress or busy periods in their lives where it's affected their cycle. It can be related to contraception and exercising excessively. So there are things that can be related to it, and often there's not any treatment required for an irregular period, although occasionally it can be a sign of an underlying condition like polycystic ovaries, particularly if you have long gaps between your periods. And what we would say generally is if you're having frequent long gaps between your periods, or if it's been more than 3 months since you've had a period and there's no reason for that, then get in touch with your GP and have a discussion about what's going on. It's really important to point out that there is a difference between having irregular periods, which is when you have your regular bleeds and the gap between them is variable, and having what we call abnormal bleeding. So that might be where you have a day's spotting and then you'll have nothing for a few days, and then you'll have another couple of days and then nothing else. And that can be a sign of an underlying issue. So if that's happening or you're having bleeding after sex, then we would want you to come and have a chat with the GP about it. So moving on from periods, let's have a brief discussion about contraception. So I've put this slide on here just to show all the different types of contraception that are available. And as you can see, there is a huge variety and they all have their own advantages and disadvantages. Looking on the left-hand side of the slide, we start with things that are more permanent, so things like sterilisation and intrauterine coils, which can get copper ones and hormonal ones that last anywhere between 5 and 10 years, depending on the type. We have things like contraceptive implants that last for 3 years, and they sit just here in your upper arm. They're a bit like a matchstick underneath the skin, but they're a fantastic form of contraception, the most effective one that we've got. So they're really good for some women. Some women will choose to use a contraceptive injection, and that's given every 12 weeks. And you can either have it at the surgery, or there are types now that you can self-administer at home, just with a review once a year, which is obviously really helpful for some women, not having to come as often. Other types of contraception that you have to use more regularly, so that's things like the vaginal ring. So that's a thin plastic ring that sits at the top of the vagina and just slowly releases a hormone. There's the contraceptive patch and contraceptive pills. So the patches usually change once a week and the pills are daily. And then there's the barrier method. So that's things like condoms and the diaphragm. Another thing worth mentioning is fertility awareness, and that is a method that people use to reduce their risk of getting pregnant. It's variable how effective it is, and nearly 1 in 2 people using that method will become pregnant within a year. So it's just worth bearing that in mind if that's something that you're doing. So how do you as a woman decide what's the right contraception for you? Well, actually, these are the kind of questions that we would encourage you to think about. So how effective is the contraception and how do you use it? How often do you need to use it? How long does it last for? What are the potential side effects and complications of it? And as your healthcare professional, I'd be thinking, well, what's your bleeding pattern like? You know, how are your periods? Are you having any irregular periods, heavy periods that perhaps contraception can help with? You know, do you have any underlying medical conditions that might increase your risk of side effects or complications? Are you on any other medication that might interact with your contraception to make it less effective? So it's really important that we're aware of things like that. What's your family history? Are you at risk of anything in particular because of your family history? So things like blood clots and you know, lifestyle factors. We talk about things like, do you smoke? What's your weight? Because all these things can affect your risks. So there's lots of things that we think about contraception. It's really hard when we're in such a big group as we are today to say this one is better than the other, because that's just not the case. Different things suit different people. So talking about the menopause. So the menopause is a topic that we talk a lot about nowadays in consultations, certainly more than we did in the past. And we see women presenting at all different stages of the menopause. So we would say the menopause is the date of the last period that you have. And we can only make that diagnosis after you've had a year without bleeding. So we make it what's called retrospectively. Anything before then we would call perimenopause. So that's at the time when you have your change in your menstrual cycle. So you might notice that your cycle's irregular or you're getting other menopausal symptoms until you've gone through the menopause and had a year without a bleed. Now, on average, women will go through the menopause at the age of 51, but it's anywhere between that range of 45 and 55. Interestingly, we know different women from different ethnicities have a different average age of menopause. So Pakistani women, for example, will go through the menopause on average at 47, so 4 years earlier than the UK average. Anybody who goes through the menopause between 40 and 45, so that's when they had their last period in that age range, we would call that an early menopause. And that is important just to note, because actually for these women, they might benefit from hormone replacement therapy to reduce their risk of health problems in the long term, particularly affecting the heart and their bones. And there are a small group of women, so about 1 in 100 will go through what we call premature ovarian failure. And that's a menopause that's particularly early, under the age of 40. And it's really important, if you're under 40 and you're not having periods, and it's not for any particular reason, for example, a side effect of your contraception, that you let somebody know about it, because we'd want to be trying to work out why that was the case. And it may be that it's important to offer you treatment to improve your health for the future. So what happens when we go through the menopause? So we go through something that we call the menopause transition. And you'll see in the first part of the graph, when women are premenopausal, they have this nice steady pattern of estrogen and progesterone levels going up and down with a nice predictable period with that little pink square happening at regular intervals. And at some point, typically in your mid-40s, you'll start to have a change. And what you'll notice is that actually things are less predictable, and your estrogen levels will go up and they'll go down, and then they might go really low and then they'll go back up again. And they'll really fluctuate, and your progesterone levels will go up, but they won't go up in that regular pattern. So your periods won't come at a regular pattern. You'll start to have those irregular cycles that we talked about. So what women see is they see that things are changing before they actually go through the menopause. And this period of life, this perimenopause, can last for up to 10 years. So it can be for quite a long time. And then eventually, at some point, your estrogen levels drop and they'll stay low. And at that point, you won't have any more periods, and we'll say you've been through the menopause. And as we said, for most people, that's about the age of 51. And then you go on to the next stage, which is the postmenopausal period. And that's for the rest of your lives, obviously, once you've gone through that stage. So what does this mean in terms of how we feel as women? So menopausal symptoms vary widely. So there's the traditional ones that you'll hear about. So things like hot flushes, insomnia, that's poor sleep, palpitations is a common symptom that people report, mood swings, irritability, just not feeling like their usual self. Some women get vaginal dryness, they get itching, they just get soreness. That could be including when they're having sex or afterwards. Some women will actually find that they pass urine more frequently. And other women will find that their joints start to ache and they feel more tired than they normally do. There are other symptoms as well that aren't listed here, things like dry skin, things like tinnitus, where you get extra ringing noises in your ear, that actually have all been proven to be related to menopause for some women. So there's a huge spectrum of things. And one thing that I would really recommend is there's something called the Green Score Symptom Checker, and we can put a link to that at the end of the presentation. But that's a really good way of looking at what are the possible symptoms that might be related to your menopause and keeping track of what's going on. And these symptoms can last anywhere between 2 and 5 years on average, but actually some women will have symptoms for more than 15 years. And that happens to about 10% of women. So some women have quite long periods with having menopausal symptoms. And about a quarter of them will have quite severe symptoms that are debilitating and really affect their lives. So it's quite a significant issue for women, and that's why we want to talk about it today, because we want to really encourage women who are finding that their menopausal symptoms are problematic to let somebody know about it and see, what can we do to support you with it. And as well as your symptoms, there are other reasons why it's useful to talk about the menopause. So when we go through the menopause, we go through what metabolic changes, that's changes in our body, like increasing what we call the bad cholesterols and an increased fat around the waist and resistance to insulin when we're processing sugars. We lose the mass in our muscles. So there's lots of things that are going on underneath the surface that as well as people's symptoms that we know are changing. And it's a really good opportunity when you go through the menopause to start thinking about your general health and, what can you do to look after your health? Things like, are you eating a healthy diet? Do you get that regular exercise of, 30 minutes aerobic activity where you're getting breathless 5 times a week? So it's a kind of a good prompt for women to look at kind of their health and looking after their future health for the next, 20, 30, 40 years. We know in terms of the vasculature, so that's your blood vessels, it affects the heart, so you're at higher risk of things like angina and heart attacks when you've been through the menopause, and it affects the brain in terms of risk of stroke and dementia. And it can also affect your bones, so your density in your bones is lower, and that means that you're at higher risk of something called osteoporosis, which is a condition where your bones are more brittle and you're more likely to have breaks, particularly in areas like the hips, the wrist and the spine. So it's important to be looking after your general health. And as we said before, if you do go through an early menopause, then please do let us know, because we'd be wanting to look at actually, can we do something to intervene and replace your hormones so that you don't go through the menopause till closer to the average age of 51. So for that reason, anybody who goes through an earlier menopause, so under the age of 45, we would recommend considering hormone replacement therapy, and that is to reduce your risk of heart disease, is to reduce your risk of osteoporosis. Talking a little bit more about general effects of the menopause. So we know that, it can affect work. So about nearly half of women think that they feel that their symptoms have negatively impacted their work, and nearly half again have had to take time off work. And when they said that they wouldn't, feel comfortable to say what it was that was causing the problem. Aside from work, the enjoyable things in life, over a third of women don't feel as outgoing. Women feel that they're not as good company. Women feel more isolated. It affects people's relationships. So again, half of women feel that their sex lives are affected by the menopause, and they just didn't feel as sexy in terms of their well-being and how they felt about themselves. Lots of people, the partners, feel that they don't really understand what's going on, how they can support their partners, and it causes issues. So it's not just the impact on the woman, but it's the impact on the people around her at work and her friends and her partner. So it's a really kind of widespread thing. It's not just menopausal women, it's the rest of society as well that need to be aware of what's happening at this period of women's lives. So what can we do? So talked a little bit about the lifestyle changes, and we can talk a little bit more about that after the presentation, because this is an area that Lisa particularly knows a lot about. But we talk about exercising, and that's trying to just do that regular exercise. It doesn't have to be for really long periods, but just enough to get your heart working and get you a little bit breathless. Ideally 5 times a week, but ultimately, whatever you're doing, if you're not exercising at all and you can get exercising once a week, then that's brilliant. That's progress, and you can work to build upon that. Certainly you don't have to all be running marathons. You just have to be thinking about it and improving your general health. And talking about a healthy diet, so trying to avoid processed foods, keeping it a healthy weight. There's some really good resources from the Eat Well guide about portions and different what components you have in your meal, your protein, your carbohydrates, your fats. So that's kind of really useful, just practical, sensible advice. And again, we can put some links through to that as well. Stopping smoking. So stopping smoking can help with your symptoms. So it's important to be thinking about that, and also with your general health as well. And we've talked a lot about your vessels and your risk of heart disease and stroke, and again, stopping smoking. There's definite benefit to thinking about doing that. We know that things like exercise, they actually increase the size of the hippocampus as part of your brain, and that's related to things like memory and learning. So when women are struggling in the menopause with brain fog and recall, we know that there are changes in the brain through exercise that can improve these areas. And it just increases the muscle strength that we talk about that you lose when you go through the menopause. It reduces your menopausal symptoms. So there's really good evidence for exercise and these lifestyle changes. Now, we know that some people, need further help to manage their symptoms, and that's where we start looking at the different things that we can access through our healthcare professionals. So, obviously, there's hormone replacement therapy, which I'll go on to talk about in a few minutes. But there are also non-hormonal therapies, and that includes things like antidepressant medication. There's complementary therapies, so that's things like CBT, and again, we'll talk a little bit about those as well. So what's hormone replacement therapy? Well, hormone replacement therapy, it usually involves 2 hormones. So we have the estrogen, which is what treats your menopausal symptoms, and we have the progesterone, which is what protects the endometrium, that's the lining of the womb. And we have 2 different types of regimens, so sequential or cyclical, which is where you take your estrogen every day, but you have estrogen every day in some form, and you have progesterone for just some of the days, so usually 2 weeks of the month, so that you have a bleed generally after that. And that's for women who haven't gone through the menopause and had their last period yet. Other women will have what we call a continuous regimen, and that's where you have the same every day in terms of estrogen and progesterone. There are other women who don't need progesterone, and if you don't have a womb, so you've had a hysterectomy, for example, you wouldn't necessarily need the progesterone because you don't have the endometrial lining of the womb to protect. So these women will just be on an estrogen-only HRT where they have the same every day. Now, it is important to point out that there's a slight change in women who have endometriosis. So that's where they have the lining of the womb, the endometrial tissue, in other parts of the body as well as inside the womb. And they may need progesterone because even if they've had their womb removed, because there might be some endometrial tissue in other places. But speak to your GP if that applies to you. And what we know is there are benefits and risks of using HRT, but generally the benefits of using HRT to treat women who have got symptoms will outweigh the risks for the majority of women. So what HRT, what hormone replacement therapy do we have? So this is just a sample of some of the things that are available, because there are lots and lots of products. But your estrogen, which is what treats your symptoms, comes in different forms. So it comes as a tablet. It can also come as a gel. So some of you may have heard of Estrogel, which is the pump or Sandrina sachets. It can come as a patch. Everell's a common brand that you might have heard of. And it can come as a spray, which is Lenzetto. Now, the tablets and the sprays and the gels you would need to use every day. The patches are, most of them tend to be twice a week, or there are a couple of weekly patches available. Now, how do you get your progestogen? So in terms of forms of progesterone, so the main two that we have available is the micronized progesterone tablet that you may have heard of. That's called Utrogestin. That's very similar to the progesterone that we produce in our body. So it's thought to perhaps be one of the safest ways of giving you progestogen. It also helps people with sleep, because one of the side effects, it can make you feel sleepy. So you take it at bedtime, and that can be a real lifesaver for women who are struggling with sleep as part of the menopausal symptoms. Another option we have is the Merino, which is the hormonal coil that goes inside the womb, in the uterus. Now, you may have heard of this. I've obviously mentioned it when we're talking about contraception, because it's also used as a contraception and as a treatment for heavy bleeding. But we can actually use that as the progesterone part of your hormone replacement therapy to protect the lining of the womb for up to 5 years. So again, that's a really good option for people who are having bleeding problems and need contraception, as well as requiring HRT. And there are also combined preparations as well. So we're a bit more limited in terms of what we have available, but there are patches, combined patches. That's either Everel Conti or Everel Sequi, depending whether you need to have your progesterone every day or for just part of the month. And there are tablets, so you may have come across these things like Femistin or Clearvance. So ultimately, there's lots of different preparations of HRT, and part of it depends a little bit in terms of what you're wanting and what you need. So what are the benefits and the risks of hormone replacement therapy? Well, the main benefit that we have is that it reduces the severity of menopausal symptoms, and that's the reason that we give hormone replacement therapy for the majority of women. Obviously, there are women who are younger, and for those women in particular, the women who are under 45, they need the benefit of reducing the risk of osteoporosis, so that's the thinning of the bones and breaks of the bones, and your risk of cardiovascular disease, so things like your heart attacks and your strokes in the future. Now, older women will also get that benefit when they take HRT. So women who are over the age of 45. What we do know, however, is there are risks with any treatment, and there's thought to be an increased risk of breast cancer. That's the main risk that we need to be aware of. Now, how much is that increase in risk? Well, we say there's probably an additional 5 in 1,000 diagnoses per 1,000. For 1,000 women, 5 more women will have a diagnosis of breast cancer over 5 years of taking HRT. Now, that is an increase in diagnosis of breast cancer. It's not an increase in death rates from breast cancer, but it is a diagnosis and potentially treatment, and we do need to be aware of this. So we do recommend, particularly for women who are using hormone replacement therapy, to check their breasts regularly, to make sure they attend for breast cancer screening. We'll talk a little bit more about that in a few minutes. For women who choose to take their estrogen orally, so either as a combined oral estrogen or as an oral estrogen tablet on its own, there's an increased risk of blood clots and there's an increased risk of strokes. So it might be, if you're somebody who has risk factors for these already, so that's things like being a smoker, having a family history, having a higher weight, that certain types of hormone replacement therapy may not be recommended. But again, this is an individual decision to look at with your clinician. And here's just a little bit more information about the breast cancer risk. So, as we said, we know that on average, 23 women will unfortunately be diagnosed with breast cancer out of every 1,000 women in their early 50s. And there is a slight increase for those women who are taking hormone replacement therapy, particularly with progesterone in it. Now, it's important to know that actually that increase is actually not as much as the increase of having a glass of wine every night, or having being overweight, having a body mass index of more than 30. And it is not that dissimilar to that of women who are smoking. So although there is an increase in risk, it's not that dissimilar for the increase in risk that we see from other factors. So you need to be aware of it, but you need to put that into the context of other risk factors as well, and how debilitating are your symptoms and what the potential benefits as well. Now, as well as hormone replacement therapy, there are specific therapies that we can give to help with menopausal symptoms that affect what we call the genitourinary tract. So that's the vulva, the vagina, the bladder. And this is things like having, your tissue in your vagina becomes thinner, it becomes less elastic, your balance of your microorganism changes, and you get change your vaginal discharge and your mucus. And all of this can cause symptoms like soreness or dryness or itching or irritation. It can cause discomfort during sex. It can cause people to pass urine more frequently because there's estrogen receptors in the bladder. And it affects a lot of women. It affects about 50% of women. Now, hormone replacement therapy can help with that, but there are other treatments as well. So generally just looking at your skincare, so avoiding using harsh products on your vulva. You don't need to use vigorous soaps and be washing vigorously. Just a nice, or even a plain emollient is the best thing that you can use. Moisturizers and lubricants, so there's lots of benefit from using those for women who want to avoid hormones. So things like moisturizers like Replens, or Silk, and then lubricants we recommend. There's a range called Yes that do oil-based and water-based products, and you can use those in combination if you're having discomfort during sex. And all those moisturizers and lubricants are available over the counter and non-hormonal, so if women want to try them, just be aware that anything oil-based can affect the effectiveness of condoms. Now, thinking about hormones, so obviously, if you have your hormone replacement therapy in the ways we've already talked about, that can give you benefit, but we can actually deliver hormones directly to the area of the problem when you're having genitourinary symptoms. So some people use an estrogen pessary, that's also known as Vagifem or Vagirux, which you pop a pessary using an applicator inside the vagina, and you do it every night for 2 weeks, and then you do it a couple of times a week long term to maintain the benefits. You can do a similar thing with estrogen cream, which again is applied with an applicator using the same regime into the vagina. And there's also an estrogen ring that you can change every 3 months, and that's a very thin plastic ring that just sits at the top of the vagina, and that's good for women who don't want to, or who struggle to use the daily estrogen or twice weekly estrogen. So there are various different options, and for some women who, for various reasons, aren't able to have estrogen hormone replacement therapy that affects the rest of the body, they are sometimes able to have estrogen that's delivered directly to the vagina. So again, if you're having symptoms, come and talk to us, because there's lots of different things available. We did mention briefly non-hormonal therapy. So these are things like SSRI medications. So there's medications like paroxetine, fluoxetine, citalopram, sertraline, and SNRIs, which are a similar category medication, venlafaxine. Now, women may be on these for other reasons, so things like low mood and anxiety, but they can have benefit for hot flushes. If there's women who are wanting to avoid hormones, there's other medications you can see listed here that are also available, things like pregabalin, gabapentin, and clonidine that can help with hot flushes too. So even if you don't want to or think hormones not suitable, there are still other options available that can be considered. Now, we've mentioned testosterone, and I can see that somebody's asked a question about testosterone. So there's a lot of discussion about testosterone, and testosterone is a hormone that we all have in the body, and it's natural that our levels diminish as time goes on. Now, for some women, that's not a problem. It doesn't affect how they are. But there are some women who it causes changes, and the main change that we see is that it can affect their libido, so their interest in sex, their sexual desire. Now, it's complicated because, as you'll appreciate, lots of things affect our libido. So it's not just our biology and our hormone levels, but it's what's going on in our lives. How do we feel about our bodies? Are we stressed? Have we got family commitments? Are we busy at work? Are we feeling low in our mood? What's going on in our relationship? Is there pressure there? Is your partner got health issues? Are you actually spending time together? So there's lots of other things that can affect your libido, but we do know that hormones can do, and estrogen can improve libido. So the first thing we think about doing if people are having issues in terms of low libido, and we've looked at other issues, and we're thinking about, do we look at hormones? The first thing we do is replace your estrogen using the conventional hormone replacement therapies that we've talked about. Now, for some women who have had their estrogen replaced and are postmenopausal, so finished having their periods, we do know that by replacing testosterone, we can give further benefit to their libido. But really, the evidence is only limited. So it's only limited to women who have been through the menopause, who have had their estrogen replaced and are struggling with a low libido. They will benefit from testosterone. There is lots of discussion about whether there's other symptoms that improve with testosterone, or whether women who are earlier in the menopause transition will benefit, but we just don't have the evidence to say that's the clear case. So we would in the NHS prescribe it for any other purpose than for postmenopausal women with low libido. Other things to think about in terms of managing menopausal symptoms, there's actually really good evidence for cognitive behavioural therapy, and that's therapy which looks either self-guided or you can also have guided cognitive behavioural therapy in this area for menopausal symptoms, accessed through the My Wellbeing College, that we can put the link up to the Bradford Talking Therapies. So what we know is that actually looking at that link between our physical symptoms, the hot flushes, we're thinking about the thoughts and how we feel about those symptoms can affect how we behave in response to those symptoms when they happen, and the severity of the symptoms. So there is good evidence that that can be helpful. There's some evidence for things like black cohosh and St John's wort, and there are other things that can be considered, but have limited evidence. I think the key with these other complementary therapies is making sure that you're not going to do any harm, and making sure that what you're taking is safe. So if you are going to go down this route, it is worth looking out for a logo that says THR, which just means that it's a more regulated product in terms of what it contains is what it should contain. So just bear that in mind. And if you're concerned about other medications and whether it might affect it, you can always check with your local pharmacist. So we've talked a bit about menopause, and we've talked through those different life stages of the woman. So now I think it'd be useful just to spend a bit of time talking about cancer screening. So cancer screening is where we test for signs of cancer in people who don't have symptoms. And we do this because we want to detect cancer when it's early and treatment's going to be more successful. And ultimately, we do screening because we know that it saves lives from cancer without causing too much harm or risk. Now, it's important to say that this is for people who don't have symptoms. So if you have symptoms and you're worried about cancer, don't wait for your screening invitation to come through. Contact your GP. So, talking about cervical cancer. So cervical cancer affects 3,000 women every year in the UK. But we know that actually by taking a small sample of cells from the cervix, we can detect abnormal cell changes that might turn into cancer and intervene to do something about it. So all women that are registered with a GP will get an invitation to come and have their screening done, and that'll be every 3 years once you're 25 until the age of 49, and then every 5 years between the age of 50 and 64. Now, this is a fairly quick procedure. It only takes about 5 minutes. The whole process the actual procedure takes less than 5 minutes. The appointment only takes about 10 minutes. And what we do is we put a thin plastic tube into the vagina, just open it up so that we can see the cervix, use a soft brush, and just send a sample of those cells to the laboratory to have a look at. And what they do nowadays is they look for something called the HPV vaccine virus. And we know that if that HPV virus isn't there, it's unlikely that there'll be any cell changes. So they'll just call you back in either 3 to 5 years, depending on your age. If they do see that HPV virus, they'll have a look at the sample in a bit more detail. And if there's any concern about abnormalities, they'll ask you to come and see somebody at the hospital where they can have a closer examination. And if there isn't any abnormalities, but you've got that HPV virus there, then they would re-offer you a screening test, a smear test in a year's time. So it has changed a little over the last few years, but it's because actually we know that this is the most effective way to pick up women who have got changes that might develop into cancer. And we know that actually by offering this programme, we save 2,000 lives a year. So it's really important to offer this. And, we know that some people are hesitant about this. If you want to talk through your kind of concerns as a clinician, we're more than happy to talk to people beforehand. We are happy to offer you an extended appointment if you feel that you need extra time. Things like breathing exercises and listening to music can be helpful. You can bring someone with you for support. You might find it more comfortable to wear a skirt or a dress to your appointment. So we'll do what we can to make you as comfortable as possible when you come for your screening test. Just going to briefly mention the HPV vaccine. So, the human papilloma virus vaccine, that is to reduce the risk of this HPV virus because it circulates quite a lot in the community and it comes and goes. But actually now we offer a vaccine against high risk types of HPV to children aged 12 and 13 years in year 8 of school. And we know that that reduces their risk of getting cervical cancer and things like genital warts and throat cancer as well, because there's less damage of cell changes to the tissue without that virus being present. So that's something that we'll see as time goes on, hopefully the benefits of, as we see more and more people who've had this vaccine. Other forms of cancer that affect women, so breast cancer is really common, unfortunately. There's over 500,000 women a year diagnosed with breast cancer. So we offer 3 yearly screening with mammograms to women once they turn 50, and we carry on with that until they're 71 years of age. And we do this because we know these mammograms help us detect breast cancers early. And the whole process, again, the actual imaging, the scans take a few minutes, although the whole appointment can last up to 30 minutes because usually the radiographer will ask you a few questions just about your breasts, any changes, any concerns. And with a mammogram, you'll have 4 x-rays, so 2 on each side by a female radiographer that will then go to be looked at, and you'll get your results by post, usually within a couple of weeks. Again, if you're anxious about breast screening, you can request an extended appointment so you've got that little bit more time, or if you've had any issues in the past. And if you've got any, if there's any concerns from your screening test, they'll offer you an appointment at the breast clinic where they can look into things in a bit more detail. Now, although we start at 50, you may not receive your first invitation until you turn 53, so it's just worth bearing that in mind. And although we finish at 71, you can carry on having breast screening. So if you contact your local breast screening unit, for us that's Penine Screening Services, you can request ongoing screening once you're over 70. And we do recommend women who are using hormone replacement therapy and perhaps have that slightly higher risk to think about doing that. And again, we'll just talk briefly about checking your breasts. So there's just a quick guide about how to check your breasts. Ideally to try and do it once a month and just get to know what's normal for you. Best in the shower or lying down. Use the flat of your fingers. So hold your palm flat, use the flat of your fingers and just go in a circular motion around the breast, under the arm and up to the collarbone, just to feel over the lymph nodes as well. And looking for any lumps or bumps or skin changes. And there's a brilliant website here called Know Your Lemons. And again, we can put a link to that where you can see the different types of changes that we would recommend that you speak to somebody about if they happen. And then the last thing that we'll talk about briefly is ovarian cancer. And we're not going to talk too much about that because unfortunately we don't have a screening programme available because we haven't found anything that's effective. But it does affect 7,500 women a year. And we would recommend if you're getting frequent episodes, so more than 12 times a month of these beat symptoms, so bloating that's persistent and doesn't come and go, difficulty eating and feeling very full, abdominal pain and changes with your bowels and your bladder, that you should speak to somebody about it because you may need to have a blood test for your ovarian hormone and an ultrasound scan to make sure there's not a problem with your ovaries. So although we don't have screening and they've tried, unfortunately, and not found anything that would benefit it, if you have got any concerns about symptoms, just be aware of what you're looking out for and speak to somebody if that happens. So we've had a very quick whistle-stop tour of some of the main aspects of women's health. As I said, there's things that we've not talked about. I could talk all week about women's health, but hopefully that's just been a bit of an introduction to women's health issues, and we'll move on to some questions and see what people have been asking. So looking at the chat, I can see that we've got some of those links that we talked about. So things like talking therapies and menopause support. So there's lots of things on there. Now, thinking about questions that people have asked. So should I ask for hormone replacement therapy during the menopause? Well, Lisa, do you want to take this one? Oh, I can't hear you, Lisa. Do you want to just start again?
Nice. Good cue.
Perfect.
I've been thinking about
Thank you.
It's a very difficult question to answer because it's very personal. A bit like pregnancy and labour, everyone is so different when it goes to your body changes. So some people might want to access earlier, some people might want to access later. But I think using the green score is a really good way to actually gauge what's happening in your body, and also perhaps feedback from your family or your husband if they're saying, oh, look, you're not right, you're not yourself, your mood's changed, or you're not sleeping, so therefore your mood's changed. There's so many things that impact us during the menopausal change. I'm postmenopause, and the journey was interesting. So I think it's a personal statement, and I don't think there is any wrong time to access. And I think sometimes coming to speak to people, whether you go to the Menopause Cafe, whether you access our social prescribers, whether you access information online, it's about getting to know what you want and what's changed and what you're not happy with. And I think it's worth coming to have that conversation. And you may walk away saying, actually, it's not the right time for me, but I've got the information I need and I will come back when I'm ready, or alternative therapies. So yeah, there's no wrong or right answer for that one. But I think if you feel you need help, then come and speak to someone.
Thank
Is
you,
that
Lisa.
fair?
Yeah, I completely agree. I think it's a very individualized decision. But, certainly if you're thinking about it and you want to come and talk to somebody, come and talk to us. By coming to talk to us doesn't mean you have to have HRT, but it means we can perhaps answer some of the questions that you've got and talk more specifically than we have tonight about how different things relate to you and your health and your well-being. And as Lisa said, there's other things as well out there that really help with menopause as well as HRT. So it's worth considering all these things too. So you've got another question on here is about women struggling with long periods of debilitating symptoms and discussion about whether these symptoms are related to stress or depression and what to do when you're in this situation. And this is unfortunately really quite common because some of our menopausal symptoms are really specific. So we know things like having a change in your menstrual cycle in terms of your cycle length. We know things like having hot flushes are generally quite specific to the menopause. So we can say if that's happening that, that's the sign that you're probably related to the menopause. But some menopausal symptoms, so things like tiredness, things that low mood, things like general aches, just aren't as specific. And there are other things that can cause them. So it can be difficult, as patients, as clinicians, to work out what's going to be helpful. Is it actually treating depression or is it actually menopausal symptoms and therefore hormone replacement therapy might be helpful? So sometimes it can take a while to get to the bottom of these things. I think what I would say is that we are, ultimately our goal as clinicians is to help you. And it's we work together. We all, we work as part of a team with our patients, but we do everything we can to try and help with your symptoms. But unfortunately, sometimes we just don't get it right straight away, and it is a case of trial and error. And every woman responds to things differently as well. So if something isn't suiting you, don't be afraid to come back and have a discussion again, or actually, I've tried this, or things have changed with these symptoms, because if you're still struggling, then come back and talk to us and we can talk about different things. Lisa, do you want to add anything to that one?
No, I just think you're right. We're all so different. We're not going to get it right first time sometimes. And I think you come to the room with other conditions. Some people might have fibromyalgia, which very mimics menopause and some of the symptoms. So sometimes it's very individualized care we're trying to give. And a lot of our staff have gone through training. A lot of our social prescribers have gone through training. They're setting up different forums to have these discussions for people to access and maybe do a bit of networking, which is what you would do for everything else as well. So yeah, we don't always get it right. Sometimes we do, which is fantastic for some of our ladies. We've also set up the specialist menopause clinic where if you've gone through the whole system and perhaps you're still not getting relief, the GP can refer you into our clinic to see us at a specialised place. And I think we're working really hard to provide a wide range to help people. So yeah.
Still on topic of menopause, because obviously that's a really popular one at the moment. So somebody's asked if there are blood tests to diagnose whether you're menopausal. So there is a blood test that we sometimes use to help us decide whether a woman's menopausal. But what we actually know is that if you're over the age of 45 and you've got menopausal symptoms, there's no value to doing the blood test because it won't tell us exactly where you are in terms of when your periods are going to stop. We know that you're probably in that menopause transition. And actually the main benefit is from looking at, well, what symptoms are you having and what are the options in terms of helping manage that. So actually a blood test isn't going to change anything. There's a slight difference in younger women. So women who are certainly under 40, we would definitely be recommending blood tests because if you're menopausal, we need to be clear about that, and we'd offer you different support if you're under the age of 40 and you've gone through the menopause than if you're over 40. And women who are 40 to 45, we may consider a blood test to give us a bit more of a guide as to where you are. That again would help us, particularly if you're in that younger age bracket and your symptoms are not as clear, it can be helpful. And when we talk about the blood test, it's the follicle stimulating hormone, the FSH level, because when you get to the menopause, you don't have as much estrogen, you don't produce eggs in the same regular rate, so your body is sending out lots of this FSH, follicle stimulating hormone, to your ovaries saying, come on, let's make some more eggs, and your ovaries are saying, no, we're tired, we're getting to the end of our egg supply. But that blood test level goes up, so that can be helpful. We do know that it fluctuates during the cycle. So sometimes we will ask you to repeat that blood test 6 weeks later to make sure that it's not just a high level of that timing of your cycle, it's consistently high, which will be more suggested if you're being menopausal. So there is a blood test. It can be useful, but actually, in all honesty, for the majority of women, we don't tend to use it because most women are over 45. We're happy they've got typical symptoms, and it's not going to change what we do, what your blood level shows. Another question about side effects of HRT. So this is a really good question. There are side effects of HRT. There's risks, as we've talked about already, but there are side effects. And when you start estrogen, you can notice, particularly if you've not had estrogen for a long time, that you might get breast tenderness, you might feel sickly, you might feel bloated, and that can improve. It often does get better after 6 to 8 weeks. So we usually, when we start HRT, encourage women to stay on it for 3 months to get a real feel for, is it helping and are the side effects persisting? But it's worth just being aware of that because, women, understandably say, oh, I feel awful, I don't feel like myself, but it does settle. It's just your body's response to getting more estrogen than it's been used to of recent times. Other side effects that we see, so bleeding is a big one that we see as a side effect of HRT. And I can see Lisa's reaction to that because we talk lots about it. And we know that when we change your HRT or you start HRT, that within the first 3 months, it's quite common to have some bleeding. We like to know about it, so we review everyone after 3 months, and we want to know what's happening with your bleeding. And if it's not settling, we'll want to, potentially we might change your HRT slightly or keep an eye on it, make sure it has gone completely by 6 months. Because if you're having persistent bleeding, it may need investigation. To make sure there's nothing else going on that's causing any problems with the lining of the womb. So we like to know if you're having bleeding so that we can try and manage it, A, for your benefit if you're having bleeding problems, but B, so we can make sure that we've resolved it before we have to start thinking, well, actually, is there anything worrying going on? Other side effects? Lisa?
I think it's probably when we over-estrogenize somebody and what that feels like to them as well. Because I think sometimes our dose changes one way and the other, depending on how further on we are in a menopause. And sometimes we think, oh, I need more because I'm feeling this way. And actually, it can make you more anxious. It can change your mood. It can give you these side effects that really make you think your menopause is getting worse. But actually, it could be that we haven't quite got the level right for that patient. And I think it's important to sort of remember that, because I think there is an instinct to just keep on going up and up and up when actually perhaps not quite the right way to approach this.
Yeah, and it's about it's not just about prescribing HRT. Sometimes it's de-prescribing HRT and actually reducing doses because women feel better, and our goal is the same as yours in terms of helping you feel better, and that's what we're all working towards. When we're looking at menopause care. Lovely. So thank you for that question. That's a really good one. So another question here from Carol. So this is a bit about osteoporosis and dairy intake. So osteoporosis affects lots and lots of women who are postmenopausal, and now women live a lot longer than we used to. It's much more of an issue because things like wrist fractures and spinal fractures and hip fractures can be really debilitating later on. So we want to try and intervene before people are at risk of these conditions. So obviously hormone replacement therapy can be helpful. There are other ways of managing osteoporosis, and we try and pick up women who we think are at higher risk. The question was about dairy, and it is important to make sure your body has, what we say, the building blocks for your bones. So that's your dairy intake, but also your vitamin D. And dairy, we know where that comes from in our diet. There's a really good calcium calculator that we can pop a link to that will show you can use, and it'll say, okay, this is how much I'm having. Am I getting enough? And if you're not getting enough, let somebody know, because it may be that you need calcium supplements. But also vitamin D, and that comes from a few foods, but generally it comes from the sunlight. And as you can all see, that sunlight in this country is unpredictable, unreliable, and we don't really get enough of it. And what that means is that quite a lot of people, particularly people with darker skin who spend a lot of time indoors, have low vitamin D levels. And it is important that your vitamin D levels are sufficient. So, you can have your vitamin D level checked. If there's any suggestion of you having a low vitamin D, we would recommend a supplement. And these can be bought very cheaply from the pharmacy, either 400 units or 10 micrograms is the standard dose. Some people will recommend a slightly higher dose just to make sure that you're getting enough vitamin D. And then other lifestyle things, so weight bearing exercise, not smoking, low alcohol intake, all these things reduce your risk of osteoporosis. So these are things that you can do as well, Carol, to try and reduce your risk as much as possible.
And I think if we take a hint from countries that don't actually eat a lot of dairy, they might have lots of figs, lentils, beans, things like that. Almonds are a really good one. Sardines helps with our vitamin D's. So you can actually enhance your diet and add a little bit more in if that's the way you prefer to go. So figs are very rich actually in calcium. So have a look at some of the options on websites for that.
Yeah, thank you. The British Dietetic Association do some really good leaflets about your nutritional intake. So if you're wanting to look at, what has calcium in it, they do some really good leaflets. So again, we can put links to there if you're wanting to have a look at where you can get calcium, because there's the obvious things like dairy, but as Lisa said, there's lots of unexpected places though you can get dairy in your diet too. So obviously the first thing, if you can replace it in your diet, that's the best option. Then if not, we'd be thinking about supplements. So other questions that we've had, we talked a lot about menopause. There's a question about fertility here, and I'm conscious that we've not really talked a lot about fertility here just because there's so much we could talk about. But in terms of people having fertility problems, so fertility problems are really common. About 1 in 7 couples will experience fertility problems at some point. That doesn't always mean getting pregnant when you've not had children. There are people who have had children before who have what we call secondary infertility and struggle to get pregnant. And there's lots of reasons why this can be the case. So sometimes it can be because you're not producing the eggs regularly. So that's things like polycystic ovarian syndrome. And that might be the case if you're not having regular periods, or you've got things like acne or lots of hair, not facial hair. There's things like structural problems. So actually the eggs are not getting to where they need to be. There might be scarring from previous gynecological problems or infections. It might be that there's a male issue in terms of the sperm, for whatever reason, isn't the quality that it needs to be, for lots of different various reasons. But it's worth being aware, particularly in men. Lifestyle things are important. So things like, not smoking, low alcohol intake, avoiding exposures to chemicals can all be a factor. Unfortunately, there are a lot of people where fertility is unexplained, and we don't know why they aren't conceiving. We can do what we would usually do is we'd say if you've been trying to conceive for a year, or if you're over 35 or have known gynecological problems and you've been trying to conceive for 6 months, and nothing's happened, then speak to somebody about it, and we can start doing some investigations to see if we can find a cause and something that we can treat. And we do basic tests, things like blood tests, things like semen samples, things like ultrasounds, just to see if we can find any answers, and then refer you on to the fertility specialist who can talk in a lot more detail. So I think really to sum it up, there are lots of causes of fertility problems that we know about. There are lots that we don't know why that is the case. But if you have been trying to conceive for a year or 6 months and you've got known problems with conceiving, or you're a bit older, you're over 35, then come and speak to somebody, because we'd start looking at what we could do to help. Okay, any other questions that we've got? I'm just looking in the chat. Has anybody got anything else they'd like to ask? So we had the question about testosterone. Should I take testosterone? Certainly we wouldn't say that you should take testosterone. Lots of women will not have testosterone during the menopause and feel very well without it. That we are constantly gathering more evidence, and I'm sure lots of menopausal care and evidence about it is rapidly increasing in volume, and what we're doing, even compared to 1 year ago, 5 years ago, 10 years ago, has changed, because we're learning lots and lots more about it, which is fantastic. But at the moment, all the evidence that we've looked at doesn't suggest that there's any clear benefit from testosterone, unless you're in that group of women who are postmenopausal, you've finished having your periods, you've replaced your estrogen, we've looked at all those other things that affect your libido, then you might benefit from testosterone. And usually what we do is we'd see you in the menopause specialist clinic, have a discussion about things, do your testosterone levels to check that they're not too high. We might offer you a 6-month trial. But actually, if it's not helping by 6 months' time, then you're not going to get any benefit from it. So, some women continue it and find that it is helpful, but some women do just find actually it's not making any difference, in which case, like anything we take, if it's not helping, don't carry on taking it. So, certainly you don't need testosterone. There are some women who benefit from it, but you certainly don't need it. Lovely. Anything you want to add, Lisa, before we finish?
I think if anyone's really interested in looking a bit further, we're guided by the British Menopause Society, and they can have a look online about information with testosterone and everything. That's who guides our practice, and perhaps it's a good way of looking. Yeah.
Thank you, Lisa. So thank you everybody for joining us tonight. It's been lovely to have so many people wanting to find out more about women's health. You know, me and Lisa are absolutely passionate about it, and we're here trying to improve the health of all the women in this area. As we said, there's lots of different aspects to think about, and we've literally just covered the tip of the iceberg tonight. But you know, on a personal level, hopefully you found this helpful. You know, please talk to your clinicians if you feel that there are issues, because there's lots that we can offer and we can discuss and work with you to improve your health. So thank you everybody for joining us.
Yeah, thank you from me too, and I'll see you in the clinic.
Bye bye.